Yes. I also would like to appreciate the moderator, Assistant Professor Tri Yunis Miko, the faculty members, including our MC, Assistant Professor Dr. Trisari, Department of Epidemiology, our professor, all faculty members joining this event, student, our beloved student and participant in this lecture. Without further delay, let's begin. Hope all of us can enjoy and attain meaningful insight given by Professor Julie in this general lecture. May God bless all of us and thank you very much. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
I'm sure everyone are excited to hear the lecture. But before that, Prof. Mondastri has a souvenir, small souvenir, something for you to remember us. Yeah, talking of appreciation. Prof. Julie, we still have something for you. Another souvenir from the department. I'm sure they all look good on you. Our pleasure, Prof. Julie. Uh, so we can start the lecture, Prof. Do you want to stand over here? Yeah, whenever more convenient for you, Prof.
Hi. Terima, selamat pagi. Can you all see me? Okay. So terima kasih, Prof. Marco, Dr. Aya. I know you both have to go for important other meetings, but thank you very much for the warm introduction. Terima kasih, Dr. Miko. It is wonderful to be here and to meet you finally after all our collaborations together back in 2022, 21 and 2023 as well. We've done a lot of work together and it is the first time we have met. And also wonderful to meet you, Octarinda Fitri, and thank you for coming along today. And I know there are people online as well. Very warm welcome to you as well. I have a little something I want to say. Saya senang untuk berada di sini. Thank you. I'm with Adi Tinesia. She is Indonesian Australian. She works with our team and she has been a wonderful guide for me in learning some Indonesian phrases. But unfortunately, I'm only starting to learn Bahasa Indonesia, so I will continue in English. So, do we have a clicker, or will I just tell you to go to the next slide? Next slide, please. Today, I'm going to talk about global trends in immunization, the things that influence vaccine uptake, what you can do to improve vaccine uptake, and I will also focus on some of the work we have done to address hesitancy about vaccination, which I know is a very pressing problem in Indonesia and parts of Indonesia in particular, as we learned last week when we attended a workshop with UNICEF and the Ministry of Health and leaders from different provinces. Next slide, please. Just a little bit about our team. So I lead with another person, with Kerry Wiley, the Social and Behavioural Insights in Immunisation Research Group at the University of Sydney. We sit in the School of Public Health, and our aim is to build knowledge and capacity in social sciences in immunisation. Our campus, as you can see there from the photograph, is a very beautiful campus. I think that your campus competes with our campus. You have a beautiful campus here at Universitas Indonesia. So it is wonderful to be here and to experience the lush green campus that you have. Next slide, please. I just saw Yoel. Lovely to see you. Yoel will be hopefully starting a PhD with us later this year, and it's the first time I've been able to meet him, so this is very exciting. Hello. Okay, so we have had some challenges with COVID-19. This is from these are countries in the WHO Southeast Asia region, and it shows a decline in vaccination rates during COVID-19. So the blue line is the proportion of children who received one dose of the diphtheria, tetanus, pertussis vaccine, DTP. That reduced during COVID-19. But there has been some recovery. So that is largely thanks to India and Indonesia, who have worked very hard Indonesia, and also in Nepal. So these are countries in the Southeast Asian region. Can I just ask that people mute their microphones because we're hearing.
Menurut saya kalau saya baca bahan modul itu tuh ada komponen penting yang bisa jadi kayak key point.
Dengan tidak vaksinasi, is that right? With no vaccination, there will be many more millions of deaths each year. That's the top line compared to what we have with vaccination. And vaccination is terms of quality of life, health and well-being, and the economy as well. Because if you're preventing disease, you don't have to spend so much on healthcare. Next slide, please. Vaccination confidence has also declined globally. So this slide is showing, you won't be able to see the detail, but it shows a series of countries where they have measured the belief in importance of vaccination over time. So they looked at whether the people in the country support vaccination over several years. And since the start of the pandemic, vaccine confidence in childhood vaccines has declined in many countries, according to this survey. Hopefully, we'll see some recovery. But Indonesia is the second last country there. But if you click again, please, you'll see that this is actually a bigger graph. Another click. So Indonesia sits in the middle of that graph. The countries with the biggest decline in vaccination, the grey bars, include Papua New Guinea and North Korea. So many countries have seen a decline in confidence in vaccines. Next slide, please. And the schedules are also increasingly complex. So this is Addie's vaccination record from 1998. Next click. This is the schedule now. There are more vaccines on the childhood vaccination schedule, and parents and healthcare providers are concerned about the number of needles that children get, which is something that UL will be looking at in his research. Next slide. And how many people have seen this image? Addie sent it to me. This is a young mum on TikTok talking about why she does not vaccinate her baby. And it caused quite a reaction, didn't it? Yeah. So there are people who oppose vaccination and they share their messages on social media. The most compelling messages are stories. So if someone tells a story about how their child was affected by a vaccine, that will influence other people. But people also are able to critically evaluate what they see on social media. And as much as we research social media and the messages, we also need to research the audiences, because the audiences are what's most important, not the messages. What people do with the messages, not what messages do to people. Next click. So this is showing all the vaccine ingredients that anti-vax messages like to put out there. They want to make vaccines look poisonous and scary. And they'll add all sorts of scary names: formaldehyde, antifreeze, aluminium, all these heavy metals. Some of these things are in vaccines in very safe components, but the anti-vax messaging wants to make it look scary. Click again, please. These are the syndromes and diseases that anti-vax writings have said vaccines cause: chronic fatigue syndrome, epilepsy, arthritis, cancer, autism. All of these things have featured in anti-vaccination writing. And when you think about what's common to these things, it's often they're mysterious. We often don't know their cause, and we're wanting to understand why they happen. And vaccines are given to a lot of people, and it is natural for people to think about, what happened to me before I got this disease? Well, I was vaccinated. Surely the vaccine caused it. The vaccine doesn't cause these things. But when people think the vaccine does, they can share those messages. Click again, please. But vaccination opposition to vaccination is as old as the practice. And this is showing a caricature from the 19th century where people are depicted growing cow-like features out of their bovine features out of their bodies, because the smallpox vaccine was sourced using bovine features because it came from cowpox. Next slide, please. But when we think about what influences vaccination decisions, we need to go below the surface. Somebody might tell you why they don't vaccinate, and they'll come up with all sorts of arguments and beliefs. But often what's underneath that are the most important drivers of decision making. So people might be part of a social group where it's more common to avoid vaccination. They want to belong to that group. People want to have a choice in what they do. Whole communities, community leaders might want to choose what they do and not follow the government's edict, the government's recommendation. People might have had traumatic experiences with the healthcare system. They might have mistrust. There may be poor experiences of health service, including racism, bad process. And people want to keep their bodies pure and free of what are seen as cocktails, chemical cocktails, that vaccines can be depicted as by anti-vaccination writing. So all of these things are known to be linked to vaccine refusal and are the core drivers of vaccine refusal. So you might ask somebody about their attitudes, but their attitudes will often come from experiences and values. Next slide. But it's not just what goes on in our heads that influences vaccination. We also have structural barriers to vaccination, policy barriers to vaccination. And this slide is showing inequity between different regions. So the black dots at the top are showing different countries in the Southeast Asia region and their national DTP3 coverage. So in Indonesia, it's around 85%. Just look at the grey bars. So that's in 2022, they looked at the lowest performing districts in each of the countries. So it showed that around 60% of children in the lowest performing Indonesian districts were vaccinated with DTP3. So it shows that there are big gaps between the highly vaccinated and the less vaccinated. And that's an inequity issue that needs to be addressed. Next slide. Also, gender affects vaccination uptake. So this is a global analysis which shows the relationship between the proportion of children vaccinated, so vaccination coverage, and gender, and shows that the more gender inequality, the lower vaccination rates. Next slide. So what do we do when we want to understand these things, when we want to measure the causes of low vaccination? The things that we can ask people about, we ask about these things. We ask about their thinking, the way they think and feel, their confidence in the benefits and safety of vaccines. We ask about the social processes, whether their family and friends want them to get their child vaccinated, whether their community and religious leaders want them to, whether their provider, their healthcare worker, is recommending vaccination, whether the mother has decision autonomy in the household. Then we look at motivation, we look at practical issues, and then vaccination itself is the behaviour. So the behaviour is the grey box, and the other boxes are the things that drive that behaviour. And they're the things we measure in our work. Next. And they are the things that we measured in our collaboration with Dr. Miko, Octarinda, Fitriani and the team, Lintang, who can't be here. This was a study that we partnered with Universitas Indonesia and UNICEF with to look at the impact of COVID-19 on routine immunisation of children in Indonesia, on maternal and child health, and we surveyed caregivers and healthcare workers, and also we talked to community and religious leaders. Now, when I say we did, Dr. Miko and his team led that work in the data collection, and we worked with them from afar in Sydney. So I'll just give you a few results from this study. But before I go on, I just want to find out how much longer I've got so I can pace myself and speed up if needed. So how much more time, Dr. Miko? 30? 30? 30? Okay. I should finish before then. You'll be glad to know. Next slide, please. So what we learned from the healthcare workers in NTB and Central Java, sorry, this is the survey of caregivers, was that most people thought vaccines were important for their child. Right? Most of the caregivers said that, so 85.5% said vaccines are very important for their child, and 13.5% said they're moderately important. Most of the people, so 93%, said that they would want their child, their family and friends would want their child to be vaccinated. Social norms are very influential. If your family want you to vaccinate your child, you are more likely to do it. Most of the people planned to vaccinate their child fully, 96%. But only 67% said it was very easy to get routine immunisation for their children. Next slide, please. We asked the families whose children were missing vaccines, right? So they were not up to date with their vaccines, what the main reason was. And then we analysed the results and grouped them into categories. So this was what we call qualitative content analysis. And again, really huge thanks to Dr. Miko and Octorindo for this work as well. So the main reason that the child was not up to date wasn't because they were hesitant. It was because their child or household member was sick at the time. So what that says to me is that some people are holding off on vaccinating their children because they can't get out of the house. But some people are holding off vaccinating their children because their child is slightly unwell and they think their child shouldn't be vaccinated when actually they can. We call this a false contraindication. And you can see the other reasons there. Next slide, please. Thank you. I know you're very busy there. Thank you for your work. We surveyed healthcare workers. The team surveyed healthcare workers as well. And they asked them about stockouts of routine vaccines. Now, this is during the pandemic. So in fact, there had been quite a few stockouts. Most healthcare workers experienced stockouts of the polio vaccine, of the DTP, Hep B and Hib vaccine, and so forth. So sometimes parents were turning up to the services and being turned away. Next slide, please. So governments often like to blame hesitancy. So they like to blame hesitancy when they're asked about why uptake is low. And that is partly because hesitancy is a problem, but sometimes there are other problems that the government needs to fix. So blaming hesitancy can let governments off the hook. So we need to measure the reasons for low uptake and not just assume. We need to talk to communities and not just assume. And I know Indonesia is an extremely diverse country, and we only looked at NTB and Central Java. This particular survey was not in Aceh, although Dr. Miko's team did do research in Aceh in 2020 and found much more hesitancy, as you can imagine. So I want to talk now about what we do about this, because you can measure the determinants of vaccination, but you actually need to do something about it. You can't just measure it and walk away. So the next slide, and this comes from the guidebook you see on the right, which is a guidance that WHO produced, and we were part of that working group to help countries measure the reasons for low uptake. It includes surveys for parents and caregivers, like the one we used in part with the team at UE, and qualitative interview guides, and also COVID-19 vaccination tools. And we're also developing further tools for malaria vaccines, for HPV vaccination, and for influenza vaccination. Next slide. So what works? In the guidebook, we've mapped those different barriers, so the thinking, feeling, the social processes, the practical issues, to interventions that we know work to improve vaccine uptake. Some of them work better than others. So a communication-based intervention usually doesn't work very much. It usually has small effect sizes in your trials. But if you combine it with other things, you've got some more chance of success. But still, if people need to know that a vaccine is due for their child or for themselves, they need to know that. And therefore, campaigns to inform people about vaccination can make a difference. A little example on the right is where South Africa used a BESD survey. They learnt that people weren't aware of how to get the COVID vaccine, and they that informed a 6 steps to getting vaccinated flyer. Social norms, so community engagement works, and positive social norm messages like that little social media sticker you see, I got my COVID vaccine. Working with vaccine champions and advocates works, and that's a screenshot. That's a photograph there you see with religious leaders from lower coverage provinces in Indonesia that we were part of last week. Things like reminders, reducing costs, service quality improvement, on-site vaccination, default appointments, incentives, requirements, they all work in terms of the practical sort of aspects of intervening with vaccination. And there's an example of an app that we use in Australia to remind parents about vaccination. Next slide, please. Okay, let's talk about hesitancy, because even though I say hesitancy is not the only problem, it is a problem. And there are some things that we've learned about how to deal with it. My PhD was done in 1999 to 2001, and it was on understanding vaccination controversies. And I researched the anti-vaccination movement in Australia, and I looked at how anti-vaccination messages affected parents, how providers responded to them, and what the anti-vaccination lobby were doing in Australia. So it's a real issue, and we've learned a lot about what to do about it through our work. The things that work the best to address hesitancy are community engagement, number one, talking with communities, not to them, and interpersonal communication, particularly from healthcare providers. So cadres, pediatricians, other healthcare workers. Next slide, please. When you look at when you look at the biggest reason for people to be hesitant, it often comes down to trust. Who is telling me this, and can I trust them? And that works in with the social processes that you saw earlier. So this is a midwife. This picture here is a cadre from Aceh. Her name is Evie, and she came to the workshop last week, and she told us a story. And I apologize to Evie if I get the story slightly wrong, but this is my understanding of it. She went to vaccinate a child in a household in a village in Aceh, and the family met her, the father met her at the door with a cutting implement or a machete or a small sword, and said, I don't want you to vaccinate my child, it's not safe. So she left. Later, that father came to the healthcare service because he had symptoms of tuberculosis. And in fact, he was diagnosed with tuberculosis and he was treated, I think, with it as well. Later, that family said, you can vaccinate our child, because Evie and the health service had developed trust. They cared for this father and he saw that they had good intentions, they had empathy, and he said, okay, you can vaccinate the family now. So that's a wonderful example of the importance of relationships, local community leaders, and of supporting people like Evie Susanti. So when we think about trust, we need to think about what makes somebody trustworthy, worthy of trust. They need to be competent, right? They need to know a little bit about vaccination. They need to be objective. People will often will ask, well, who's paying you? I run workshops with migrant groups in Australia. And one day, halfway through the workshop, they were sharing all their concerns about vaccination. And I said, oh, I don't get any funding from the pharmaceutical industry. I think I've been sponsored to travel by a vaccine manufacturer once, but I don't get any direct funding for my research from industry. And that man said to me, oh, right, so now we can trust you. This is really important to people. People need to be fair and represent all points of view. Consistency is important with trust. Consistency between words and actions as well. Good faith and empathy. And in terms of the system, this is from work that Addie has led, looking at the things that addressed hesitancy during COVID-19 among Indigenous communities globally. So Indigenous Aboriginal communities in Australia, in Canada, the US, South America. And what they found was that it was important to recognize local knowledge, local language, local history and culture. And of course, in Indonesia, such a diverse nation, that will very much apply here. Community involvement and ownership in the vaccination program, convenient and culturally sensitive services, and well-supported workforce. Next slide, please. One of the things we've been doing with WHO is developing bits of information briefs about each of those interventions. So you saw community engagement works. What is it when it comes to vaccination? So Addie has led the development of these intervention briefs that describe what is community engagement, how do you do it? And we've done quite a lot of community engagement work. We've run workshops, as I said, in Australia with Aboriginal communities, with refugee and migrant leaders. And what we do is we meet with those community leaders before the workshop and we tailor the workshop. And we often will have the local community leaders leading the workshop as well. Next slide, please. So Addie is just going to come up briefly and talk about the results of the research that she did with Octarinda as part of the qualitative analysis with this UE project.
Thanks, Julie. I'll just quickly go through this project. So this was part of the larger project that Julie introduced. Burinda, oh no, this Burinda and Dr. Miko also was obviously a huge help in this, and Burinda and I worked together in this qualitative analysis of the role of community leaders and religious leaders in Jawa Tengah and Nusa Tenggara Barat. And what we found was that despite the different opinions and beliefs that the religious and community leaders had on COVID-19 as a disease and COVID-19 vaccination, they were very involved in throughout the COVID-19 vaccination process. So here you'll see all the different activities that they were involved in. So the first is that they informed the communities on, for example, when the vaccination clinic is happening. They modeled and reinforced behaviors, for example, by showcasing that they too got vaccinated, or even things like wearing a mask outside. They educated and advocated for the COVID-19 vaccine. So they talked about why they talked to the community about why they took up the vaccination. They also helped a lot with practicality, so setting up tables, helping with administration, for example. They reassured the community about the vaccination and why they think that it's safe. But also importantly, they bridged between government and community. And I think that's one of the most important thing is that community and religious leaders, because they so grassroots, they have direct communications with the community and are able to listen to them about any issues that they're experiencing with the COVID-19 vaccination. So for example, they were able to hear from the community that a particular clinic was too far for the community members to go to, and so they talk to the puskesmas to advocate so that they bring the clinic closer to them, so that more people are able to go to the COVID-19 vaccine clinic more easily. Thanks.
So as you can see, engaging well with community leaders helped the COVID vaccine program in so many different ways and in some very practical ways as well. Next slide, please. The other thing that works to address hesitancy is dialogue-based interventions. That's where you support a healthcare worker to counsel a parent or a caregiver about vaccination. So this picture that you see here is from the 1950s in Australia, in Sydney, where we live. And that's not me. The baby is not me, by the way. It's my older brother. He's now 68 years of age. Now, this is an image of my grandmother and my mother. My grandmother turned to natural health in 1941. So she was against vaccination. She believed that she needed to raise her children naturally and not put those toxins into their bodies. She was very vigilant with all her 4 children. She fed them a very healthy diet. She cared for them intensively. She was a very intelligent woman. I think she was a bit bored, and her work was in her children and their diet and lifestyle. Now, my mother was raised to be against vaccination as well, but she had 3 boys. I was not yet born. She had 3 young boys, and one of the boys was in a playground. He hit his head on the playground equipment. It bled. Mum went to the GP, the family doctor, and the doctor heard that Mum had not given a tetanus vaccine to any of her children. And the doctor was very shocked and recommended strongly that she change her mind. Mum went home. She thought about it. She dreamt about it. She talked to my father. She went back the next day and she got all 3 boys vaccinated. That was because of a healthcare worker intervention. Healthcare worker recommendations are powerful, but they need to be done carefully. If a doctor had said that to my grandmother, she would have been very offended and she would not have gone ever again. So it has to be tailored to the person and where they are at. Next slide, please. By the way, my mum is still alive. She's 86. She calls herself a radical pro-vaccinator. So she's very, very positive about vaccination. When we think about how we approach people who are worried about vaccines, often we think of 2 things, being pro or anti-vaccination. That's not the case. There's a spectrum of attitudes to vaccination. And we start with people who are unquestioning acceptors. They don't think much about it. They just go along. There are people who are cautious acceptors who will vaccinate with some concerns about safety. I'm a cautious acceptor because I know that there are some very small risks from vaccination. There are people who are hesitant acceptors, so they have a lot of questions and concerns. There are people who are so hesitant they will select or delay out certain vaccines. And there are other people who will refuse all vaccines, and we call them decliners. So the hesitant people sit in the second 2 rows. Click again, please, because I want to point out that the anti-vaccination activist movement will sit at the top there. So there'll be people who don't want to vaccinate at all, but they're not activists. So we need to be nuanced in the way we approach this issue. 2 more clicks. And again, thank you. So we've got the thumbs up is the supportive, the accepting, the ready to vaccinate. The question mark is the hesitant, and the stop hand is the declining vaccination. Next slide. So what we did in our research, which was looking at we developed a communication approach to vaccine hesitancy. And we look, you know, in healthcare, you have clinical pathways. Well, we have communication pathways. Most people are ready to vaccinate. So you go through the normal checklist, the informed consent procedures, explaining what will happen afterwards. It's very important. And you do that well, you prevent them becoming hesitant in the future. For people who are unsure, who are hesitant, you might want to ask them some more questions, address their concerns. Don't jump in immediately when they raise questions. Listen to all their questions, then address their concerns. And by then you know which are the biggest concerns. And you can use resources that we've developed, answering common questions, weighing up risk and benefit. Your aim is to get that child vaccinated. Some people are declining, like my grandmother. They may not vaccinate. You can try to encourage them. You should always recommend they vaccinate, but do it in a very respectful, gentle way if you're sure that they're declining. And there are certain ways of telling if someone's declining vaccination. In those sheets you see at the start, these are communication tips for health workers. And then there are resources for parents and caregivers. Next slide, please. So that's called SKY, Sharing Knowledge about Immunisation. And it's been used through Australia and in some of the work that we've done with other countries as well. So I said that there were tips for health workers in having these conversations. Well, if you click again, we'll see the tips sheet for when parents are declining vaccination. So you're listening. Tell me, can I ask you why you've decided not to vaccinate, right? You're asking permission to discuss. Offer to share your knowledge, right? It's very respectful of the person's autonomy. Now, I know that in Indonesia, the cultural approach to communication will be different, and it will differ across provinces and districts as well. This is what we've learned for Australia. So it doesn't necessarily apply, but you can get some good tips here. Acknowledge parents. I can see you've done a lot of thinking about this. I can see you're worried about his safety. You're trying to be a good mum. Explore their motivations to reconsider. Are there any diseases you're concerned about him getting? Maybe they're concerned about tetanus or measles. Would you be willing to start with a measles vaccine today? And then you can see how it goes, and we can offer some more later if that goes okay. So you're still recommending, you're still moving them towards vaccination, but you're doing it in a more gentle way, because if you have a fight with these parents, they won't come back, certainly in Australia context. Next slide, please. I mentioned the resources for hesitant parents. These are the 5 major concerns that Australian parents had about vaccination. And you'll see some of them are shared with parents in Indonesia as well. People are worried about autism and whether vaccines cause autism. They're worried about the ingredients of vaccines. Why are there so many vaccines on the schedule? How do they affect the baby? And how do they know they're safe? What sort of testing is done? And each of those we give a 2-page information sheet that's structured according to research on debunking myths. Next slide. The package has an e-learning module, a mobile version, and handout cards. So if a provider wants a parent to see the information, they can take the card away and use the QR code. Next slide, please. Okay, so I'm going to summarize, but I've got a picture of the Sultan here, the Sultan, the 9th Sultan from Yogyakarta. We were privileged to visit Yogyakarta a couple of days ago, and we visited the palace and we looked at the paintings of the sultans. And what I was struck with was the fact that the sultans have the sumping to symbolize listening. So part of their job is to listen. They are a respected leader. They're the sultan, but they're also listening to their people. And I think that's a theme today. We need to listen to communities through talking with them, engaging with them through research, behavioural research. Next slide. Great, thank you. Back up. Thank you, that's good. So childhood vaccination coverage has declined in many countries because of the pandemic, and there has been some recovery, but in many nations, the recovery has not been enough. And some cohorts of children have missed vaccines. So there'll be children in Indonesia who missed out on vaccines during COVID-19 and have not been caught up. So this is a concern. There are many things that cause children to be under-vaccinated or unvaccinated. To understand what to do about that, we need to listen first, then act, because then our action is informed by evidence. Start with community listening and research, if you can manage that, and map the solutions to the reasons. We have amazing science that informs vaccination programs, but the best and safest vaccines will not reach people if they don't want the vaccines or they can't get the vaccines. And we can use behavioural science to inform that part of the vaccination programs. Click again, please. We need to evaluate the efforts that we do and keep improving programs. And again. So in finishing, I'd just like to acknowledge I trained as a nurse and a midwife many years ago. And I want to acknowledge the work that nurses and midwives do, GPs, pediatricians, all health workers do in keeping children vaccinated. It's hard work. They have to be trained and keep their training up to date. They sometimes face challenging situations, but they do an amazing job, and I really want to acknowledge their work. And also thank you for your attention today. I wish you all the very best with your research, with your studies, and thank you again, Dr. Miko and your colleagues for having me speak today. Thank you.
Yes. Okay. Thank you. Here. Okay. Thank you for your delivery, your lecture. Very nice and very comprehensive. I think I let time to be moderator here because the MC don't speak that I become a moderator previously. Okay, now I'm trying to moderate this discussion. But before the discussion, I beg apologies for all participants uh, because supposed to be today until 3 May 2025 in OE is supposed to be online lecture, and we have it is a combined lecture. It is offline and online. I beg apologize for this put information on UI because the information come 2 days ago, and then we think why become online, and then we ask permission for the dean. We have the combined online for this lecture. And then the deans give our permission for today lecture. Okay. Now, the second one's before the discussion, question and answer session. I think I will read the CV of Professor Julia Lix first, because if you don't know who's Professor Julia Lix, I think uh, we don't have any uh, any perception or any knowledge about who Professor Julia Lix. I think I get the uh, CV from the website. I- but I think the website in the University of Sydney, the CV of Professor Julia Lix, it is 16 pages. Very long. Okay, then ada. I think I will just read some important parts. Uh, ada, yeah, I think before the slide shows in the Zoom, I think good morning for participant in the Zoom, and also good morning participant in the class in this room. Okay, I think I read here. Professor Julia Lix, it is the investigator uh, in Susan Wakil. So sorry, Susan Wakil. Wakil is not vice. Susan Wakil is the name of the School of Nursing and Midwifery Faculty of Medicine and Health, University of Sydney. And then also the adjunct professor, the Professor Julie, adjunct professor in University of Sydney, the member of its Institute of Infectious Disease, and also visiting professor in National Center for Immunization Research and Surveillance. It is Professor Julie Lix. And
Nanti yang tanya dua-dua sama lakon. 20 orang.
okay, I think the education of Professor Julie Lix, Doctor of Philosophy in 2003, Department of Public Health and Community Medicine, University of Sydney. The Master of Public Health in 1998, in Department of Public Health and Community Medicine, University of Sydney, and a certificate of Mastery and Theory and Practice 1992 in Northern Sydney area Mastery School. Okay, I think this is the important things of Professor Julie Lelix, and we know who is the Professor Julie Lelix. Now we come up with the question and answer session. I think I give the floor for here in the room and also in the Zoom in online. Okay. First, maybe the second, and okay, three. Yeah, okay. I give first to the 3% in the room. Namanya?
Check.
Yep.
Okay. Thank you for this opportunity. I'm Novi. I'm a graduated student from master degree in this Faculty of Public Health. Thank you, Prof. Julie, for your presentation. And I acknowledge that University of Sydney is one of the most beautiful campus in the world. So yeah, I hope someday I can take a picture in front of that university. Okay, for my first question here, your presentation said that there are some factors that infect the vaccination decision, and one of them is trauma. So I think that's a special condition because like the mother already have her own experience, maybe like uh, her first child that maybe have some trauma. So maybe you can share the experience how to handle this condition, uh, this particular condition. That's my first question. And then the second one, as far as I know, there's certain different side effect from the vaccine to the genetic factors. And if it can lead to the misunderstanding, it can lead to the racism, uh, misunderstanding information. Like, oh, the black genetics, like the black people have more severe side effects than white or the Asian. So, uh, can you explain that vision? How can the like the community engagement and then the interpersonal communication can solve like to explain more about the genetics like side effect and lead into the racism so the people cannot have the misunderstanding about that. Thank you.
Oke, ke penanya kedua silakan. Ya.
Yes. Okay.
Yep.
Good morning, Professor Julie and sir. My name is Dahlia. I graduated from North Sumatra University, not from this faculty, but I'm so curious to attend here because I want to ask. I have seen your slide, Professor Julie, then I looked the Myanmar for DT3 coverage fraction. Why is the bar only the gray. I see only the gray diagrams,
The
and then
coverage.
yeah, that's very low. Yes. Oh, yeah. Okay. And then there's the second about the vaccine hesitancy, because I have involved from measles rubella campaigns in Indonesia 2017 and 2018 in Java Island, and then the in 2018 in outside Java. Then my experience is very 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 hard to fight with vaccine hesitancy. That is a very problem in outside Java. Maybe would you please share the vaccine hesitancy in Australia? Is it same with Indonesia or not? And what is the best solution for tackle the vaccine hesitancy? And the last about the gender equity, because my experience in this field, mother in Indonesia we have a culture that mother is not the making decision, because the head of the family is father. So when the health facility health services goes to the household, ask their children to vaccines, and then the mother will say, I will ask my husband first. Yes. So this is very I think very significant about the culture to take decision about to vaccinate or not their children. Thank you, sir and miss.
Okay, thank you. The third person.
Okay, that's thank you for to Professor Julie for the lecture materials. Really interesting. It gives such an insight to what is happening in NTB and in um, Jawa Tengah, right? So I'm interested in the way what you have told us in your material and how it links to the theory, one of the theory of behavioral change, the health belief model, the importance of the cue to action, because as you said, your mother let uh, let her kids to be vaccinated because of one accident, and the doctors, the physicians prompted her to let their her kids get vaccinated. So uh, the cues the action that is, in the rise, on the rise in Indonesia, especially through social medias, is, this narrative, as you also have put in your materials, the narrative of anti-vaccine, my child can get to through these years without having been vaccinated. um they can be alive, so why should your kids get vaccinated? um Especially in the social media. So I know that your research is more focused in local areas, but how about the social media, and how about we uh how do you what is your judgment on the narrative that is on the rising on the rise nowadays? um has the researchers, maybe have the researchers in your team um also like researched about these topic, and what are the findings that maybe give us the insights of the rising anti-vaccine narrative on the social media, and how do we tackle how we tackle those narratives as a public health practitioners. So yeah, thank you.
Okay, thank you for your question. I think Professor Julie will be respond.
Thank you for your um, very, very thoughtful questions. Addie, before we go on, I'm just letting you know that I will turn to you for one of the answers about misinformation around the HPV vaccine, because you've just been looking at that. Okay, so just so you'll get mentally ready. So, Movi, is that your name, Movi? No, sorry. Okay, so you mentioned trauma. One of our team has been doing a PhD on the relationship between traumatic experiences and vaccine hesitancy. Because what we noticed in our research was that when we talked to parents who had decided to not vaccinate their children, quite a few of them had had a traumatic experience with the birth, with the healthcare system, or with vaccinations. And what Maria Christou-Ergos found in her PhD, which is now finished and passed, is that there is a relationship between traumatic experiences and vaccination. But people can also experience vicarious trauma. And that means when you hear about someone else's trauma with vaccination, you can feel the trauma and want to avoid vaccination as well. So trauma can have a big effect on vaccination, and it is under-recognized. It is not recognized enough. What do you do about it? What Maria did was she concluded her thesis with the first start of a guide for trauma-informed services. So there are many healthcare services that are now starting to adopt trauma-informed approaches. And Maria proposed a trauma-informed vaccination service could be one where you make sure the clinic environment is welcoming, where people are treated with respect, where they're told what will happen, where there are no images of needles on the walls, because some people have needle trauma, where ideally the gender of the person vaccinating is the same as the person being as the parent being vaccinated. So if a mother comes, for a person who's experienced trauma, it can be better to have the same gender vaccinating them. I know that's not always possible. So you're not going to be asking everybody about their trauma before you vaccinate them. You can't do that. But what you can do is be aware that there may be people who have been traumatized in the past. And if they're anxious or angry, try to work with that and hold a space for them and treat them with unconditional positive regard, because sometimes anxiety and anger can come from trauma. So I guess we assume that if we assume that most people have had trauma and it might affect their vaccination experience, and we adjust according to that. You asked about whether there are genetic drivers of adverse events following vaccination. So are some races are more likely to have an adverse event from vaccination? I don't think there's any evidence of that. And I think it would be difficult to study. I think that all people have a risk of an adverse event following immunization. Most adverse events are minor and common. Redness at the injection site, a fever, but sometimes there will be a rare serious adverse event. That's a whole other topic. What we have noticed, what we've done in our research is we've done research with the Somali diaspora population in Sweden. So in Sweden, there's a large Somali community and there are high rates of autism. And the parents in that community wanted to know why autism was occurring, and vaccines were offered to them by anti-vaccination activists as the cause of the autism. So this is what they did to address it. They were engaged with the community. They worked with community leaders, Somali community leaders. They informed the healthcare workers about autism, because parents were going to the nurses in the clinic and saying, I don't want to vaccinate him because I don't want him to get autism. And the nurses didn't want to talk about it because they had no knowledge. They did not have enough knowledge about autism. So they educated the nurses, and they also brought in a Somali pediatrician who specialized in autism, in developmental pediatrics. And she ran webinars with parents. She told them what we know about autism and why we know that vaccines do not cause autism. And that made a difference as well. So it's a form of community engagement, but it's also addressing the concerns with information and respect. Resania, is that Resania? You had a question about, was it Myanmar? Did you mention Myanmar and the long grey bar, right? So that would have showed that in Myanmar, there was a big decline in confidence in vaccination, according to that research. What's happened in Myanmar, of course, is that that's been a conflict-affected setting. And because there's been the military junta takeover of the governance, many communities were not able to get vaccines, or they did not trust the system. Some of the community, managers of the vaccination program were even put into jail because some of the medical professionals were part of the protesters against the junta. So it became very difficult to provide vaccination services in Myanmar. Now, there has been some recovery, fortunately, but I think where you have a country where people aren't getting vaccines easily, it can also be easy to lose confidence in vaccination and in the program itself, particularly if you oppose the new regime. For how hard it is to fight hesitancy. Everybody finds it hard, so you're not alone. It can be very difficult. It requires time and patience. It requires building relationships with community members. One of my students did her PhD on vaccine refusal in the Byron Shire of New South Wales. This is a canton, a pocket of Australia where there is very low vaccination rates, and a lot of parents refuse vaccination. They're like my grandmother. They want to stay natural. They don't want the toxins in their children's bodies. Catherine Helps did her PhD where she talked to local healthcare providers, local midwives and parents. She learned that some of these parents would actually consider vaccination, but you had to spend a lot of time talking with them to understand their stories and their perspectives and to have very good communication skills. So I think teaching healthcare workers how to be skilled communicators is important. And you can learn communication skills. It can be innate, but you can also learn them as well and enhance your skills. But I agree, it's not easy to deal with vaccine refusal. It can be easier to deal with hesitancy because people are just on the fence and they're not sure. That's where healthcare provider recommendations are very important. Gender issues. So I won't. What I'll do for the fact that the mother will say, I need to ask the father for permission. I think one of the solutions to that is to work with fathers in the community through community engagement. We often think about women, we often frame women as being the people responsible for vaccination. We need to change the language. Families are responsible for vaccination, including fathers. Motivating fathers about vaccination, addressing, appealing to the father's motivations to vaccinate and making sure they're well informed, and also skilling up women in the family to talk within their family about vaccination. So they're ready when they go to the health service, they've already had the conversation and building their confidence to have that conversation. This is all resource intensive. So hesitancy is not an easy thing to deal with. There was a question about links to the health belief model and cues to action. These are very important. So when I did my PhD on vaccine acceptance, I used the health belief model, but I did not find it adequate to address all of the drivers of vaccination. The health belief model is really good for looking at what people's health beliefs are, but it's not so good for looking at the social determinants of vaccination. And as you say, the cues to action need a whole system around them to make them work well. The cues to action that work best with vaccination are reminders to vaccinate. SMS reminders work. If you can get the child's vaccination, you've got an electronic immunization system being established in Indonesia. If that can be used to remind parents about vaccination, that's one possibility. Recommendations work. So if a healthcare professional has an encounter with somebody for any reason, looking up whether they're due for a vaccine or their child is due for a vaccine and saying, he's due for his measles vaccine. Let's do that now. That's a cue to action. And as you say, there are more psychological cues to actions like narratives. So I think you know some of the answers to that question. I think you've got some knowledge there that is very useful that you can continue to draw on. And I hope I've understood your question correctly. What about social media? This is a huge topic. I'll say again, we can get very, very distracted by social media. People will worry about the effects of social media on other people. And that was my PhD topic. What happens when anti-vaccination messages get out there through the media? But this was before social media, actually. What do parents do with that information? And I did focus groups with parents and I asked them. And what they did with that information is they sometimes challenged it. So we need to look at parents and caregivers as people with their own critical ability. But the kinds of what I'd like to think about is you can have social media is like a seed, right? There's a social media message that is like a seed and it sits in a soil and it only grows in that soil if there's poor process, bad experiences, mistrust, certain values that are against vaccination. So think about that diagram of the plant and all the things that sit under the surface. Think about audiences. Addie has just been looking at some of the social media in the world that's out there about the HPV vaccine. So just quickly tell us some of the myths that are out there about the HPV vaccine.
Some of the myths about the HPV vaccine includes that it can affect a woman's fertility, so jadi mandul gitu kan, or that often it is seen that it would mean that the teenagers or the children getting vaccinated would become more promiscuous. There's misinformation of it relating to cancers, for example. There's misinformation. There's just so many misinformation out there from a variety of different perspectives, sort of from a health perspective, from a social cultural perspective, from a religious perspective. They all kind of interact and it's part of the misinformation for it.
One other important thing is that if you want to measure social media, if you go to Twitter, for example, don't measure the number of messages out there, measure the exposure. There might be one person putting out hundreds of tweets about vaccination, but they've got 10 followers, right? That's low exposure. High volume of messages, low exposure to the messages. You might have an influencer who has millions of followers putting out one message. That's much higher exposure, lower volume of messaging. Think about the source and their influence. What do you do about it? With misinformation, with any kind of misinformation, the research increasingly says that you inoculate people, you vaccinate them against misinformation. You tell them that they might hear that the HPV vaccine causes promiscuity, or that the measles vaccine causes autism. You might hear these things. You might hear that the COVID vaccine reduces reproductive potential. But this is why this is wrong. This is misinformation. Here's why people are saying it, and here's why it's wrong. And here is some science for you on this. And use trusted spokespeople to do that. So you're making sure the source of the good information is trusted, and that the good information is high quality and prepares people for what they might hear out there. And there's a whole science around this. And if you're interested in looking at the research in this, it's called psychological inoculation and debunking. And there's a lot of research now being funded in this area. Thank you, Dr. Miko.
Yeah, thank you, Professor Julia. I think for the second question and answer, I will give to the participant in the Zoom online. I think Prof. Hadi Pratomo already raised your hand. Please, Prof. Hadi, introduce yourself.
Yeah, thank you, Dr. Nico. Can I listen to my voice? Is it clear?
Yeah, yeah.
Hello?
Okay, very clear.
Okay. Thank you, Prof. Julie. I appreciate your presentation. And please introduce myself. I am the Hadi Pratomo, former professor at the Department of Health Education and Behavioral Sciences in this faculty. Yeah, I think you raised one of the important issue in vaccination with this hesitancy. And I think there are, global comments and also guidelines over there. In your research, I have a particular question. I'm glad that you raised the issue of trustworthiness, in the research, but you discuss only trustworthiness of the messenger and the systems. Could you elaborate, trustworthiness in terms of who is doing the analysis of the data? Okay, that's the first question. And then the second one, I wonder if you also explore, the perceived barrier of the vaccination among the neonates mothers or fathers or grandmothers. Yeah, what I mean is there any of were there any informant of your study? This baby is less than 35 days or maybe 0 to 28 days during neonatal period. Okay, please share your comment or your experience on this.
Thank you for your questions. So, Prof. Adi, could you please repeat your first question? It's just a little bit hard to hear in this room.
Oh, okay. Maybe you can also use your slides, on the trustworthiness. Can you? Is it? How do you remember when you discuss the issue of trustworthiness? You discuss
trustworthy.
Yeah,
Yes.
trustworthiness
Yes.
in terms of messengers and the system.
Yeah.
Okay. So I think in my understanding, trustworthiness is a very important issues in the qualitative research because basically it helps how the objective nature of the research to become more objective. And you did already in terms of messenger and systems, but maybe you haven't told us, what you're doing with the analysis. You have how many people for doing the coding probably, or who's doing the analysis? I hope that it should be more than one person to make it more objective. Maybe you can explain about that. Are you catching my question?
Kenzie itu yang dirawat ya? I'm just getting some help. Okay, so okay, thanks. So for trustworthiness, the first component is objectivity. And we know that if the data comes from industry, people, so pharmaceutical vaccine manufacturers, people find it much more difficult to trust the information. So what makes vaccine information more trustworthy is when the source of the information is seen to be objective, when they're not funded by a pharmaceutical industry, when they are seen as fair by the community. So in Australia, for example, we had some people who were also actually very, very good communicators. They didn't always have the best data, but they were very good communicators during COVID, and they spoke a lot in the media. So, sometimes somebody's trustworthiness doesn't always correlate with their knowledge of vaccination, unfortunately. And then some people can be extremely knowledgeable about vaccination, but because they're not so good at communicating, the communities don't trust them as much. So that's very challenging. How do you be more objective? I think transparency is the key. We use this word a lot. So to show people, you might be able to say the COVID vaccine doesn't cause infertility. This is incorrect. But one of the things that hesitant people do is that they listen to a message and they say, well, you're not talking about safety. You're not willing to talk about safety. You're not being transparent. So what we found in our research is that if you actually talk about what vaccines do cause, you can make the message more trustworthy. So with when we were developing the Sky package, we talked about the fact that we gave information to parents on what the serious rare side effects were of vaccines. And we looked at whether it reduced their confidence in vaccination, and it didn't. It increased it, because they could see we were being honest and transparent in what was known. And we were putting boundaries around where the risks were and where the risks were not. And we gave them evidence. We did focus groups. We handed the information sheets to our parent audiences in focus groups, and we watched them and what they did with that information. And they looked at the first page, they turned it over, and they looked at the second page. And I said, what are you looking at on the second page? And they said, well, we're looking at the logos. We're looking at who produced this information. Is this from the pharmaceutical industry? Is it government, or is it an independent research centre? And the independent research centre was the most trustworthy organisation, because they didn't have government agendas and they didn't have financial agendas like industry does. Now, I work with industry. They are an important stakeholder in vaccination, but I'm talking about what parents, what people see when they assess information about vaccines.
Prof. Hadi, is it answer your question?
No, I think that she didn't get up my question. Please, I read the question in the chat. Yeah.
Okay. I will read the question in the chat. Yeah.
Oh, it's in. Oh, okay. Who are the collectors of the qualitative data, and who were doing the analysis? Are you only one researcher, or have you a team, more than one person, to make it less subjective? Second question, did you have any informants who were the mother, father, or grandmother of neonates of the baby who is less than 20? So I've been presenting today research from 2 decades of research. So I've been presenting many different studies today. Your question about qualitative research is a really important one. The way we approach qualitative research in our work is that we have one or two people doing the interviews. Then we take the interview transcripts and we give them to several people on the team. We're not relying on one person's interpretation. We're relying on the interpretation of a range of people. We start to map out independently the themes that we see. Then we talk together about the findings and we agree on the main themes, and only then do we code the data. So we have somebody with a list of the themes, a definition of each theme, and they code the data. And then together we start to look at the theme sheets and what each theme is saying, and we summarize it, and then we do the analysis. So it's a very rigorous process. And that's usually how we approach our qualitative research. All research is subjective, Prof. All research is subjective, including epidemiological research, because how you define your outcome variables is often a subjective decision. So qualitative research is subjective as well. And what we do to try to reduce the impact of one person's perspective is to have a lot of people analysing the data and together agreeing on what the main themes are and testing out our hypotheses as we go, challenging them, looking for divergent cases. Have you any informants who are mothers, fathers or grandmothers? Yes. In many of our studies, we've had parents of very young children. The answers to that is yes. Thank you.
Okay, thank you. I just would like to add one comment. We don't do the research, but we did collect different information from the perinatal society, and we found that all over Indonesia there always what we call the taboo. Yeah, they don't bring to baby to the posyandu on the first month because there is a taboo that a baby was not supposed to be get out from the house until they are 35 or 40 days. That's almost in every island of the country. So do you find that phenomenon?
Sorry, Prof. They get kaku atau
Oke, Pak. Ini jelaskan aja ke bahasa Inggris.
tabu.
Ya,
Tabu.
Pak Miko. Jadi kalau dari penelitian tidak resmi kita di Perinasia itu hambatan untuk membawa bayi ke posyandu, ya.
Oh, tabu.
Ya, itu karena ada tabu tidak membawa bayi keluar sebelum usia 35 atau 40 hari. Itu hampir ada di seluruh Indonesia. Pertanyaan saya, kalau Anda pernah studi di Indonesia atau di luar negeri, ketemu nggak?
Yeah. Okay. Because here your spell is not clear. Tabu, I know tabu. No, I think the issue is your taboo. It is a belief from the people in the and any place in Indonesia. There is a belief that if you bring out from the house baby before 20 or 1 month, it is a taboo. And then how to bring the babies 1 month olds and before to go to posyandu.
Well, being from Australia and not being part of this culture and knowing this taboo well, I think my answer is, what is done in Indonesia about this? Are there people who have developed a good approach to this that we can learn from? It might be that some families need home visiting so that the infant doesn't have to come out of the house. there might be work that can be done with communities, but if it's a strong taboo, then it might be very difficult to change. And we know that home visiting is effective and cost effective. So if house-to-house vaccination is needed to reach some of these harder to reach families, then that might be one solution. But I really would defer to experts in Indonesia about this issue.
Pak Miko,
Yep,
itu,
yeah.
ya itu yang menjadi tantangan kita dari segi
Yeah.
perilaku ya. Kenapa di Posyandu vaksinasi itu nggak jalan? Karena masih banyak tabu ya. Nah, setahu saya itu justru tantangan bidang kita ya. Belum terdokumentasikan ya kan intervensi yang tadi bagaimana sih apa sih yang artinya dianalisis kayak dia punya tadi, apa sih yang membuat itu tabu dari sisi mananya, kemudian bagaimana itu bisa diselesaikan. Nah, itu satu tantangan. Tapi yang saya ingin katakan itu tabunya ternyata bukan hanya di Jawa, ternyata di Sumatera ada, di Kalimantan ada, di ini ada.
Yep. Okay, Prof. I think for taboo in Indonesia, there is no solution yet. How to handle the taboo? I think people in Indonesia still don't want to bring out the babies before 1 month old. Okay, and then many factor people not come to Posyandu. I think the factor not only the taboo. There is so many factors. We have to learn with the theory. The theory come from the Professor Julia Lick's slide. It is a new one. It is BASD, Behavior and Social Driver. It is the new theory. Beside that old theory that we come from PKIP. PKIP is education and social behavior science. And then the BSD, it is from Brewer. It is the year 2017. And then our knowledge just know the theory of Lawrence Green's, the theory of Green and other ones. It is Lawrence Green's, belief models, and other ones. Green's belief model and other ones. I think Lawrence, okay. I think it is the new ones come from the Brewer. Okay, 2017. Okay, I think there is left 2 questions in the chat. I read in the chats. Okay. The first one. Okay. Can I have presentation of file of Professor Julia Lieks? Please answer. The second one, do you have any suggestion to create communication pathway in other health problem? Okay, it is the second, the first question. The second question, I currently involved in the study about primary healthcare integration in PD district in Aceh province, which is known to have a lowest immunization. It is the province have a problem with religion ones. I think you can that in your slide. The lowest immunization coverage in Indonesia. The community in PD district has a fairly lowest level of trust in healthcare. even the head of the district health office was attacked by some people when trying to encourage. Yeah, they attack the district health office staff, attacked by the people when they trying to vaccinate their children. What is appropriate approach to engage? To engage uh, with the community, and again they tries when the community is already very reluctant. I think. Thank you. This is the question. Please answer.
Thank you for those also very thoughtful and challenging questions. Yes, I'm very happy to share the slides. Other communication pathways, approaches, with other health issues. Yes, absolutely. We actually drew on communication approaches that were used in medicine and health from other areas. So we drew on understanding from what a special behavior change counseling technique called motivational interviewing or motivational counseling, which seeks to identify what people's perceived barriers to behavior change are, to acknowledge them, to engage respectfully and empathically, and to leverage, to find out the person's own motivation to change and leverage that to amplify that motivation for change. And it's been used in addiction counseling, in weight loss counseling, in several areas of behavior change. So we drew on motivational interviewing to develop SKY, and it can also be used in healthcare professionals helping people to stop smoking. So if you're interested in reading more about it, there's a very good article in the British Medical Journal on motivational interviewing. It's nice and brief, but you can just Google it as well. The second approach was the Calgary-Cambridge model of medical communication. Most medical, who's doing medicine here? Anyone? Who's learning communication in your curriculum? So who is in your course now or in the past learnt about healthcare communication as a topic in your degree? Right. So this is fairly typical around the world. Most undergraduate or pre-registration programs do not teach much about health communication, but it is a skill, and you can be a good communicator, but you can learn new skills as well. Some people want to communicate well and they need the skills. It should be taught. In the University of Cambridge and the University of Calgary, they decided to teach good medical communication. And they use this model where you elicit questions and concerns to saturation, you set an agenda, then you give the information. And that's how we structured SKY. You elicit the parents' questions and concerns to saturation. What's on their agenda? You can ask those questions in any healthcare encounter. If I go to a doctor about a skin lesion, that doctor should be asking me, what would you like to cover today? What are we going to discuss today? Because then she knows how much time she needs to give to each part of our discussion. And she also knows that if I ask one question, she doesn't answer the question then. She waits until she elicits all my questions before she segments out the time needed and addresses my question. If she's busy, she might say, we've only got time to address these two things today. Can you come back later for that one? Talking too much. One more. Oh, one more question. In Arche, you've got low. Oh gosh, it sounds like I'm crying. I've got a frog in my throat. In Arche, there are many challenges. We heard from healthcare workers in Arche last week, there are also many strengths. There's tightly connected communities. There are imams who do support vaccination. The religious leaders at the meeting last week said to us, if you reach the senior imams with information, they can sometimes feel more confident to promote vaccination. But we know that sometimes vaccination can be a religious and even a political lever. And it is a very complex issue globally. So I think working with strengths, working with imams who we know might be willing to support vaccination, informing them through workshops, and then and what they said also was that the more community-based imams needed more information about vaccines, and they also needed some skills in public speaking about vaccines. That's what they were asked about. And they also wanted to know what to do if a child has a side effect. Because if you're a religious or community leader and you're promoting vaccination and one of your community's children has a side effect, they might come back to you and say, what do we do? You said to do this and look, he's sick. So they need to be educated in the post-vaccination information as well, what to look out for and where they report side effects of vaccination. That's what the religious leaders from Aceh were saying to us last week. So again, it's asking what the leaders in those communities think are the solutions and working with those solutions. In terms of people being attacked, sometimes for a time it's not safe enough to go to a community. Healthcare workers need good security. That needs to be an investment from government. But at the highest level, negotiation, diplomacy are what have worked best when there are religious tensions around immunization.
Thank you, Professor Julie. I think okay. The last session will give from the floor here in the room. Okay, the first only one. Okay, I think only one for the last session. Question and answer. Oh, the second person. Okay, yeah, only two. Yeah, 2 person. Okay.
Uh, Thank you. Hello, Professor Julie and also Pak Miko. Very good afternoon. My name is Hannah. I'm a graduate student majoring in Community of Epidemiology. All of my question actually has been answered in our previous section, but concerned about the elderly communication skill. Here in Indonesia, we do have a stereotype that oftenly the youngest child always gonna be the one who going to take care of their parents during their elder lines. But I knew some information from my Australian friends. They say that it's not really kind of thing in is as the Australians to take care of their parents during their elder lines. So talking about the vaccine resistance and also the hesitancy, also agree things to concern, especially for vulnerable populations such as elderly, which I said before. So how do the Australian government could tackle this kind of things to ensuring that people, especially the elderly, get the benefit from vaccine, which is requires a deep understanding of vaccination itself, and how do we as the health workers wannabe could create supporting environments for health workers to deliver their high quality immunization services, especially for under immunized children. Um, that's all for me. Thank you so much.
Okay. You get the question. Okay. Okay. Well, the second one first. Okay.
Okay. Good morning, Professor Julie. I would like to raise questions. First of all, my name is Joel. I was a former UNICEF and Child staff in Indonesia. My first question is regarding about the new vaccine introduction. Julie, as we know that nowadays Indonesia is struggling with PCV2. Uh, Probably because I know that it takes a longer time to introduce this new vaccine. However, when based on my previous experience regarding MR vaccines, it takes like 5 up to 10 years that community would accept this kind of vaccine. My question is it like a trend for introducing a vaccine? Like we need time like for many years in order that communities will accept this new vaccine. And the second one is about the incentive. Based on my previous experience in Lampung province, I also saw that many parents who were hesitant or the caregivers who were hesitant, they feel that they want to bring their children to posyandu or primary healthcare for their children to be vaccinated because they receive incentives, for example, like gifts or souvenirs, and then they have intentions to bring their children vaccinated. My question is it like appropriate strategy or is it appropriate like solutions to mitigate this issue? Because in the long run, it would be like constrained in the sense that, yeah, this program would not be sustainable. And the last question is from your research about the routine immunization decline in 2022. I also had the same experience in 2022 when Indonesia did national campaign on routine immunization. The result was, I think, was aligned with my RCA rapid confidence assessment that showing parents were, I mean, hesitant to bring their children to be vaccinated because their children were sick. Unfortunately, after like several months, I observed this trend, like in Lampung province, I found that, well, every month when their children have had to be vaccinated, I think that they always give the same reasons, their children's being sick. Is it like a reason or probably like, is it a kind of their tricks like to hide their initial reasons to refuse or to be hesitant for their children being vaccinated? Thank you.
Thank you for your question. Okay, you can answer the question.
So Hannah, um, could you please just repeat the first question you had? You asked about quality serve elderly people. Just give me a short repeat of that question, please.
My first question is about how do we deliver the information for the elderly who live alone in Australia? Because here in Indonesia, we do have a kind of thing that parents are going to live with their children also, but I knew some information from my friends in Australia. It's not really common for Australian to accompany their parents during their elder line. So, is there any government in Australia could tackle this kind of things to ensuring that vaccine immunization and everything is well delivered to elderly who live alone or live with the older partner?
Yeah, thank you.
Thank you.
Great question. In Australia, we also have a very diverse nation, a very multicultural nation with many cultures, including my own Anglo culture, where we sometimes do have our elderly people live with us. We still visit our elderly, we care for them, even if they don't live in the same household. So elderly are influenced by close family members and they can help them get to the vaccination. They can encourage them to get vaccinated. We have a routine recommendation for flu vaccination in Australia for people who are 65 years and over. And it's quite well known. The government invests a lot of money in the campaigns, the big broadcast mass media campaigns to tell people it's time for your flu vaccination. And right now is our flu vaccination season. So we're campaigning right now in Australia to remind people. That's a cue to action that was mentioned earlier, the reminder from the campaign. So they work, support works, but people, once they establish a vaccination habit, getting their yearly flu vaccine, for example, or their pneumococcal vaccine. We also have the shingles vaccine, the zoster vaccine now. Once they establish that habit, they tend to go back. So if you can get them to have that first vaccine, they'll go back each year for their flu vaccine. We see very high odds ratios for being vaccinated if you've had a vaccine the year before. How do you improve quality of services? There are various things like what we call academic detailing. This is a terrible phrase, but it simply means a person goes to a practice, a posyandu, a general practice, a private clinic. They look at their vaccination records. They look at whether people are up to date. They clean the data. They help them contact people who are overdue. They help them develop plans and strategies. They help them audit and evaluate their performance. And that works according to evidence. Performance monitoring and evaluation works. Yoel, you asked 3 excellent questions. Do new vaccine programs take a long time to get established? Usually, yes. But with COVID, we saw just how quickly we can roll out a vaccine program if there's motivation and resources, and everybody in the nation is held hostage to the disease. The MR vaccine, the PCV vaccine, it takes quite a long time for health systems to adapt to the new vaccination. And that's particularly the case if it's a new schedule point. So you're not just reminding parents to come at 1, 3, 5 months of age, you're asking them to come at another point in time. You've got to update all your materials, your education, your providers. It takes time. And I really commend countries like Indonesia where they know how they do campaigns. I know that the BIAN has sometimes it works well, sometimes it doesn't work so well. But we know campaigns can have a big impact on catch-up vaccination. And countries like Indonesia are very practiced at doing big vaccination campaigns. So there are a lot of strengths there, but it is normal for a vaccine program to take some time to be established. I don't know how long it would take for PCV in Indonesia, though. In Lampung province, you mentioned people are incentivized to vaccinate. Incentives can work. The kind of incentive is important. The incentive needs to be given fairly soon after the behaviour. It needs to relate to the behaviour. It needs to be sustainable. And this is the problem with incentives. People can receive a bag of rice or they can receive money to vaccinate, but can you sustain that? And can you do it for all other aspects of primary care? If you don't pay the incentive that day, will the family get angry and threaten violence, which has happened in some countries? So in general, I would say that incentives might work from a psychological perspective, but they may not work from an implementation perspective. And in any case, isn't it better that the motivation to vaccinate comes from a belief that it's worth getting vaccinated, not just that you want money? So, you know, we use incentives in Australia. We've used them and they made a difference. But we've been able to sustain that basically because we took a welfare payment that we were already giving everybody an allowance, and we said, okay, you can only have this now if you vaccinate your children fully. So we linked an existing welfare payment to vaccination. That is ethically problematic because then if people are poor and they can't vaccinate, they get punished. So there are problems with incentives. I didn't vaccinate because my child was sick at the time. Is this just a cover for other things? I don't know. Why don't you research it? I think that is a genuine reason. Children get sick, particularly when they turn 1 year of age and their immunity drops off. Their maternal immunity goes down. They're very vulnerable to many infections. So it is very common for a child to be sick. Parents and providers also believe that if a child is sick, they shouldn't be vaccinated because that vaccine might worsen the fever. If it's a high fever, you can delay it. If it's a low fever, they can still be vaccinated. So providers need to be educated on this, and parents and caregivers do as well. But I think it is a genuine reason that children are delayed. When I first started, and I'll finish with this story, when I first started working in health promotion, I was running a program with pregnant teenagers and parenting teenagers. They were always late for their vaccinations. And you know why? Because their kids were sick a lot. They had bronchiolitis, they were in hospital. It delayed their vaccinations. They wanted to get them vaccinated. They couldn't do it on time because the kids were always sick. So I've seen it for myself as a midwife.
Thank you, Professor Jolie. I think we arrive at the end of this lecture. Thank you all participants, even both participants in the class of offline, the participant in the Zoom or online. Thank you very much for your attention. I think I would like to also to thanks for Professor Julia Lix for your lecture. Thank you very much. Very much. Maybe it is can be accounted very much. I think for the faculty, it is very lucky to have your lecture here in Indonesia, in the University of Indonesia, because you talking about the new theory of behavior. It is BSD. It is the considered as the new one. You talking about your knowledge and experience in social and behavior science or aspect of your knowledge. It is beyond my expert. I epidemiologist. Also, it is a new one for people in Department of Education and Behavior Science here. I think it is very useful for us, for the Faculty of Public Health. I think it is, please give big applause for Professor Julius. Okay, thank you very much. I think it is the end of this lecture. I close this lecture. Wassalamualaikum warahmatullahi wabarakatuh. Yeah, we can hear you.